So we saw a typical case of a patient 45 years old, had a degenerative meniscus, which led to pain and symptoms of clicking, mechanical symptoms. I think we did a great job in taking it out, doing a partial meniscectomy, keeping as much... It was not
repairable.
Exactly.
It was not a repairable lesion.
So keeping as much of the tissue as possible. And then, but we do know this started with the lesion, functional loss, more load on the cartilage, and therefore is going to end up with osteoarthritis.
So it's the beginning of the end.
Basically,
it's all this basically the beginning of the end.
That's true.
In this first episode of Meniscus Discovery Series, we will discuss in detail the anatomy,
vascularity,
biomechanics, functional biomechanics,
biology,
the importance of the alignment, and importance of the morphotype of the knee. These topics will be presented to you by the world-class faculty. So Robert, you had fantastic studies of the meniscus anatomy. So let's talk about the lateral meniscal anatomy.
I divided the meniscus into 6 different zones. In different zones they have the anatomical and the functional importance. Anatomical because they have different histological histology, and the functional because they move differently and they play, in my opinion, different role in the function of the meniscus. Zone 1 is the anterior root, like in all meniscus, in the medial lateral. At first we start from the anterior part, anterior root, we go around and we finish on the posterior root. And zone 1 is the anterior root. What does it mean? In anterior root, when you put our camera, even if you put camera to the knee, in the 90-degree flexion, more or less, can we see the anterior root of the lateral meniscus? No. Why? Because the anterior root of the lateral meniscus is covered by the ACL. ACL is in the front of it. If we cut the meniscus, the ACL, behind the ACL, we can look for some fibers of the lateral meniscus, anterior root of the lateral meniscus. When we turn it, we can see from the lateral side that in the front we have the ACL and back to the ACL with the anterior root of the lateral meniscus. Isn't it important? Well, it's a good question because actually when we do the tunnel for the ACL, well, the question is, can we destroy the anterior root of the lateral meniscus? You have to answer by yourself on the questions. But just this is an example. It's a real example that every part of the meniscus is important. If we lose the bony attachment, we lose the function of the meniscus in the mostly. Then we go to the zone 2. There is the very mobile part of the lateral meniscus. We can see that the zone 2 is covered. It's just between the anterior root and the popliteus muscle. Popliteus tendon. And if you can see the picture, you can see when I just cut it, the very thin membrane, it's like the synovium membrane, between the lateral meniscus and the tibia, there is kind of recess. We can have some kind of recess, which sometimes is described on the MRI as the cyst, which is not cyst, it's just recess which allow the movement of the meniscus on the lateral tibia plateau. And go next step. There is the, we can see the tibia plateau from the top, and you can see here that the meniscus, how the behavior of the meniscus in the full extension, which is on the left side, and the full flexion, which is on the right side. And then you can see the range of the motion of the lateral meniscus. Let's go. Next step, you can see on the right side, I just put two pictures together, and you can see the range of motion of the lateral meniscus from full extension to the full flexion. It's a really big one. And this is quite interesting, because the next step is zone 3. Zone 3 is very interesting from the anatomical point of view, from the biomechanical point of view, because the zone 3 is, I would say, there is the part of the meniscus which is not attached to the capsule anymore. It's a free space for the popliteus tendon. And here, the meniscus, this part of the lateral meniscus is very important for the meniscus mobility and stability at the same time. This is mostly the popliteus muscle area, and you can see the popliteus tendon and the meniscus, which is here next to them. When you look at this movie, you can see this is the zone 3. It means the popliteus tendon, and you can see here the popliteo-meniscal fascicles, and deep to them, there is the meniscofibular ligament. The meniscofibular ligament is very bad unknown ligament, but very important for the meniscus stability and the mobility as well. I know this is a contrast, but the mobility and stability at the same time. You have the popliteus tendon, which is here, and if you look deeper, there is the meniscofibular ligament. Meniscofibular ligament, there is no much papers, science done about that. I will just show you that. You can see with this black arrows, there is the meniscofibular ligament. Meniscofibular ligament is responsible for the anterior, limitation of the anterior movement of the lateral meniscus. It's one of the most important structures. This is the movie. You can see now I start to make some dissection, and I cut here on this movie the connections, the menisco-popliteal fascicles. And what you can see here, this is the meniscofibular ligament. Can you see that? This is really real structure which is here. It's not the joke. It's a structure, and we have to take into consideration that if we have the rupture of that, we have to think about how to manage the problem with this ligament. As long as we don't know the anatomy, we cannot treat. We don't know the injuries because we don't know the anatomy. If we don't know the structures, we don't know the injury of the structures. If we don't know the injury of the structures, we cannot treat the structures. If we don't know the structures, we don't know the function of the structures, and so on and so on and so on. That's why we have to look deeper in the anatomy. That's why we have to look for the new things. Now you can see what happened with the meniscus when I cut the meniscofibular ligament. Meniscofibular ligament, can you see that? The meniscus moves more anterior. That is important. That's why we have to remember about different even sometimes small structures, even sometimes maybe not so important in the first look, but finally very important structures which all together they can restore the full function of the meniscus, they can restore the full anatomy of the meniscus. That's obvious. Well, next zone is zone 4, between the popliteus and the zone 5, which is the also very interesting zone. This is the mostly in this zone, the meniscus is attached to the tibia. There is called tibial ligaments or coronal ligaments, and you can see with the black arrows where the meniscus is attached to the tibia. This is quite strong area, and this is quite fixed attachment of the meniscus to the posterior capsule. Then we go to the zone 5. I call it the ligamentous zone. Why the ligamentous zone? You can see on the pictures we have different attachment or connections between the lateral meniscus and the femur or tibia. We have two meniscofemoral ligaments, anterior and posterior. We have the meniscofibular tibial ligament, and we have finally the posterior root. It will come next. ML is the lateral meniscus. Then we have the Risberg ligament, which is back to the PCL, Humphrey ligament, which is in front of the PCL, and these structures here. This is the meniscotibial ligament, and the meniscotibial ligament covered the posterior root of the lateral meniscus. Different structures, I will show you how it works. Different structures covered by the posterior root is covered by that, but can allow us, if you look deeper, the meniscotibial ligament has continuity and is going around the anterior root of the lateral meniscus, and the continuity of the meniscotibial ligament is the ACL. I know, sounds strange, but it is. Now we go to the next. You can see from the front, from the top, meniscotibial ligament and posterior root of the lateral meniscus. What happened? There is the meniscotibial ligament. If you can see that, I divided these two structures, meniscotibial ligament and the posterior root. What happened when I cut it? When I cut the meniscotibial ligament, the meniscus don't change so much the mobility. But what happened when I cut the posterior root, which is quite often, if we have the ACL injury, together with the ACL injury, quite often we can observe the injury of the posterior root of the lateral meniscus. And now, what we should do, and this is the answer. Look at the movie. What happened? This is the meniscotibial ligament. This is the posterior root of the lateral meniscus. What happened when I cut it? What happened when we have such injury combined with the ACL injury? You see, this is quite strong attachment, but then the meniscus loses the stability completely. It's completely destabilized. It means if we have the posterior root injury, we should take under consideration to attach the meniscus back to the proper position. Because the lateral meniscus is responsible for the rotational stability femur on the lateral tibia plateau. So one of the components, not only one, but one of the components. If we talk about the rotational stability, we have taken into consideration the meniscus is a very important structure as well, the lateral meniscus.
And now let's talk about medial meniscus.
A couple of years ago, we published a paper in an SK journal about the medial meniscus anatomy. And you can see here, I also proposed to divide the meniscus into 5 zones. Comparing to the lateral meniscus, 6 zones, but here is 5 zones. Why? Zone 1 is the anterior root of the medial meniscus. Anterior root is, of course, the attachment of the meniscus to the bone. Very important, because without that, the meniscus is unstable. Without the good attachment of the meniscus to the bone, we cannot talk about the stability of the meniscus. And the zone 1 is usually the sharpened fibers. Zone 1 is just, has in the histology, has more structure like the ligament than the meniscus. Where starts the histology of the meniscus, which is similar to the meniscus anatomy? This histology starts. Zone 2, as I said, has 2 parts. One is between the anterior root to intermeniscal ligament, and this is the also very mobile part, which is mostly attached to the tibia and to the Hoffa fat pad. You can see the Hoffa fat pad is attached to the zone 2A. When we go to the zone 2B, zone 2B is between the intermeniscal ligament to anterior border of the MCL. What we can see here, there is the attachment of the meniscus to the femur and to the tibia. And if we look deeper, if we look from the functional point of view, this part, I know it sounds strange, but this part is the attachment from the meniscus to the femur is very similar to the ALL. It's very similar to ALL. Just give the stability of the meniscus in the rotation. If we go the next step is zone 3. Very interesting part of the meniscus, of the history of the medial meniscus. Why? Because zone 3 has 2 layers. What we call the MCL and the deep MCL. The MCL is here, But the deep MCL, there is the menisco-femoral ligament, meniscotibial ligament, coronal ligament. And if you can look, have a look at this picture, look here. In this area between the MCL and the, let's say, deep MCL, we have the vessels, small artery, we have the vein and the small nerve branches. This is the medial side. If we want to put the sutures in this area, and if we go improper with the suturing technique, we can close the vessels. If we close the vessels, we stop the healing, we stop the blood supply, we start the degeneration. And this is important. The knowledge, the understanding of the anatomy allowed us just to improve our technique, improve of our treatment. Let's go to the next area, net zone. This is very interesting. Why? Because this is the most problematic zone in the medial meniscus history, not the anatomy. This is the full of degeneration, the most injured part of the meniscus. Why? Well, my theory, because of the very special anatomy of this part. Why is the special anatomy? First of all, zone 4 starts on the posterior border of the MCL and is until the posterior root of the medial meniscus. What's so interesting in the zone 4? Well, if we look from the posterior, in the zone 4, meniscus has no attachment to the femur. There is only attachment to the tibia. You can see here, then if we go the next step, I just cut out here the window on the posterior capsule. There is the free border of the medial meniscus, and the black arrows show the attachment of the meniscus, the border between the meniscus and the synovium in the posterior part of the knee. And then deeper we have the meniscotibial ligament. And this is the presentation of the meniscotibial ligament. We can see the meniscus is attached only to the tibia, not actively to the femur. This is very important. And then we go, I will just explain soon what is so interesting in this zone 4. And now we go to the zone 5, which is the posterior root of the medial meniscus. Again, the posterior root is located under the PCL. Again, you think, if we talk about the posterior root repair, we should take into consideration that the posterior root is deep there under the PCL. It's not here. It's changing the way of thinking about the surgery as well. Can we make the meniscus shorter? Does it have any biomechanical consequences if we put the posterior root in improper place? I don't know. I don't know the answer on the question. But this is something what I have rethink when I do my surgery. I still have these pictures in front of my eyes. Yeah, I have to think about the surgery, having in my back in the head the anatomy. And now again here you can see on the histology, the beautiful histology. PCL is here when the medial meniscus is under the PCL. Also the fibers of the posterior root of the medial meniscus are the landmarks for the PCL reconstruction. The shining fibers, and we shouldn't put here the tunnel for the PCL. We go down if you want to that. And this, the knowledge, the knowing of this anatomy should help us to find the landmarks for the other surgery, not only meniscus surgery.
What an incredible journey inside the meniscus anatomy. Now I know much more about meniscal anatomy. What a fantastic videos and fantastic anatomical preparation. It's really much clearer now. So now let's look on the meniscal biology, Because meniscus have also very particular biologies, not that simple as we used to think, and thinking about only one cell type and thinking about some fibrocartilaginous structure. So we have an incredible experts in meniscal biology, which is Dan Grande and Girish Patapa, and they will tell us a lot about it. So please, Dan and Girish, the floor is yours.
The meniscus may be described as a fibrocartilaginous structure, whereby it is a mixture of collagen 1 and 2 interspersed with proteoglycans. In comparison, articular cartilage is a proteoglycan and collagen 2 rich structure with depth-dependent changes within its structure from the superficial to the deep layers of cartilage. The nucleus pulposus is similar to articular cartilage with a predominantly collagen 2 and proteoglycan rich structure. Although it has been found to have a higher proportion of proteoglycans compared to articular cartilage, enabling it to resist both compressive and torsional loading during spinal motion. It may be said that the meniscus can also be related to tendon and ligaments due to its loading characteristics, thus leading to an underlying feeling that it may be a cross between these and the described cartilages. The meniscus contains two distinct cell types: chondrocyte-like cells found within the inner meniscus and a more fibroblast-like cell type that is located in the outer meniscus. These were defined by studies by McDivitt and colleagues from human meniscus tissues. These distinct cell types are related to the region, cellular morphology, and matrix deposition. These cells are commonly described as meniscus cells, although the literature has also described these cells collectively as fibrochondrocytes, reflecting the mixed cell types within the meniscus. An additional cell type is found in the superficial layer of the meniscus, and this has been postulated that it contains a progenitor population similar to what we see in adult articular cartilage.
A variety of publications have indicated that the superficial layer, the vascularized region, and horns of the meniscus contain a stem cell-like population within its structure. Specifically, in vitro cell culture of cells from the vascularized region has shown that these cells have colony-forming capacity, are able to proliferate extensively, and undergo differentiation towards each of the three main mesenchymal lineages, specifically adipogenesis, chondrogenesis, and osteogenesis. A recent RNA-seq analysis study showed that potentially this subset of cells within the meniscus are CD146 positive, and this may be related to the vasculature and indicates the presence of pericytes, which are another name given to mesenchymal stem cells. Furthermore, recent evidence has shown that the meniscus also has a population which are Gli1 positive, and these Gli1 positive cells are found specifically in the horns and the superficial layer of the menisci. In a mouse model, it was found that loss of these Gli1 positive cells led to the onset of early OA within a mouse model, and that injection of Gli1 positive cells into a meniscus tail of the mouse helped delay the progression of OA. This latter study has only been recently published in 2021, and we need further understanding of these stem cell-like populations within the meniscus, and specifically whether these meniscus progenitors can help aid in the repair of the tissue.
Dan, biomarkers are a very fashionable topic now. So I know you have done some studies on the biomarkers, of the change on biomarkers in synovial fluid of the meniscus. So what's changing?
Meniscus health is highly correlated with the overall health of a joint, and it has been well established that knee OA and meniscus injury are often seen progressing in tandem. Synovial fluid can provide a window into the health of a joint by analysis of biomarkers. Several molecules in the meniscus can be used as biomarkers of meniscus health and disease. These include biomechanical signaling, inflammatory pathways, and anabolic-catabolic pathways. As can be expected, prostaglandin E2 is significantly elevated in the synovial fluid of subjects with meniscus tears versus control subjects. At the gene transcript level of expression, adiponectin and resistin were higher in injured meniscus and correlated with articulocartilage degeneration. Other studies have demonstrated increased MMP1, 3, and ADAMTS4 are elevated, and expression levels of TIMPs, tissue inhibitors of metalloproteases, are suppressed in a goat model of meniscus injury. These findings suggest that modulation of MMP activity, prostaglandin E2 signaling, or both could be ideal targets to possibly circumvent meniscus degeneration, delay or prevent OA development, and to promote tissue repair.
Now you know much more about the biology. We all know much more about the biology of the meniscus and about the cells, because we always thinking they are only type of cells inside the meniscus, but it's not like this, and the architecture and biology is really complex. But now we are coming close to very, very exciting and interesting part, which is functional anatomy of the meniscus and biomechanical appearance of the and behavior of the meniscus. Because meniscus plays very important role in load transmission, and that's why it's so important to face the meniscal deficiency in the proper way and understand the meniscal deficiency. So now we will talk with Scott Rodeo, we will talk with Steve Arnowski, and also Garich will be back, and after that Peter Verdonk, to explain us what will happen dynamically and from a functional point of view inside the knee when we have a meniscus or when we lose our meniscus.
So Stephen, can you tell me the difference between the medial and lateral meniscus?
So the meniscus is very, very important in terms of backing up the anterior cruciate ligament. And one of the things that people like Ed Voiditz and Chris Harner talks about all the time is when they do meniscus transplantation, it's important to make sure that the anterior cruciate ligament's intact. Because again, they work in concert. This is a little bit different than the lateral meniscus, in which obviously the lateral meniscus has about twice as much motion in terms of anterior posterior translation through the range of motion than the medial meniscus. So the lateral meniscus, doesn't have that much effect on translation. And a study by, again, Dr. Gallinat and Dr. Warren showed that to be true. They basically mimicked the same study they did on the medial meniscus with the lateral meniscus and found out that the lateral meniscus does not contribute that much to translation in the ACL insufficient knee.
So the menisci are important shock absorbers in the knee that essentially transmit load across the joint. They transmit load from the femur to the tibia. When we walk and weight bear, we put loads on the knee. That vertical load in the knee is absorbed by the meniscus, and the particular architecture and structure of the meniscus converts this load to so-called hoop stresses. So the meniscus then transmits that load right to the bone. So essentially, acting as a shock absorber, the meniscus decreases the contact stress on the articular cartilage. Now, there's a medial and a lateral meniscus. The lateral meniscus actually transmits more of the load in the lateral compartment than the medial meniscus transmits in its medial compartment. For example, in the lateral compartment, when we put weight on our leg and we walk, the lateral meniscus transmits approximately 80% of the load across the knee. And so if you have a tear in the lateral meniscus that compromises, say, 50% of the lateral meniscus, now only 40% of the load goes through the meniscus, and consequently much more load is borne on the articular cartilage. And this is why in the meniscus deficient knee, there is a more rapid progression of cartilage damage and eventual osteoarthritis. On the medial side, the medial meniscus transmits approximately 60% of the load versus 80%, as I mentioned, for the lateral. So on the medial side, 60% of the load goes to the meniscus. But again, if you lose half of that load, half of your meniscus, that is, now you've got 30% of the load transmitted by the meniscus. That's 70% load on the cartilage surface. And again, this is why we see a progression of degenerative changes on the cartilage surface and eventual osteoarthritis in the setting of meniscus loss or meniscus injury. Another important role that should be mentioned for the menisci, apart from their role in load transmission, is the role in stability. The menisci do have some role in joint stability. Both the medial and lateral meniscus have role as secondary stabilizers, for example, in knees with anterior cruciate ligament injury, which is such an important and common injury that we see. Another important function of the menisci to understand is that they have a role even in nutrition of the articular cartilage. The menisci help kind of spread synovial fluid and even compress the synovial fluid into the overlying cartilage surface, thereby aiding in nutrition of the articular cartilage.
It has been estimated that the meniscus can withstand loads up to 150 kilopascals and tensile forces of 300 megapascals, thereby indicating that these beautiful structures are of great importance within the knee joint and specifically within joint motion.
Another important factor to consider is the role of the meniscus in knee stability. The menisci serve as important secondary stabilizers in the ACL deficient knee, and cadaveric biomechanical studies demonstrate that the medial meniscus plays a role in decreasing anterior tibial translation during a simulated Lachman exam, while the lateral meniscus plays a role in rotatory stability during a pivot shift maneuver. This information is relevant to the clinician when considering meniscus allograft transplantation to replace lost meniscus function in the setting of revision ACL reconstruction.
The differing collagen bundles within the meniscus regions are related to the predominant loading modality experienced. During joint movement, the inner region is under compressive forces, lending itself to more collagen II in this area. In contrast, the outer region is predominantly under tensile stresses, and so collagen I is the more prominent collagen in this area. These circumferentially oriented bundles resist so-called hoop stresses and help contain the femoral condyle.
So it's very, very important that these meniscus actually serve a very, very important function. And if you saw back for your collagen orientation, they do that in a very specific way. The collagen is oriented like the hoops on a barrel stave. So the idea is, by the way the collagen is oriented, it takes a compressive load and translates it into a tension load. Collagen only works, at least in the meniscus and ligaments and tendons, in tension. It's like a rope. You're pulling on a rope. And so if we have a good anchor at both the anterior and posterior attachments of the menisci, and then we load it, well, the meniscus tends to spread out or stretch, if you will, and that stretching is resisted by the collagen. So we're taking a compressive load and translating it, because of the design of the meniscus, into a tensile load. So Mother Nature was very, very innovative when she designed the menisci and allowed it to work as it does.
Understanding knee osteoarthritis implicates to understand that it is a biomechanical disease driven by two main drivers, being genetics and the load. And we need to understand that knee osteoarthritis very often starts with meniscus degeneration. Basically, it should not be called osteoarthritis, it should be called menisc arthritis or something very similar. If you're looking just specifically to load, then load means that we have to look into meniscus functional loss due to an injury. You need to look into BMI, the body mass of that patient, his activity level, and the alignment, either in varus or in valgus. And so if we're looking just to the fact what happens to the load if you lose your meniscus because of a tear or an injury. So what happens to the joint load once you are confronted with a meniscus tear? Basically, you lose function of the meniscus, and that implicates that the load is no longer transferred to the meniscus as such, but is now transferred to the cartilage as a whole. You see an increase of the load on the cartilage.
So Peter, load is important. This is different, a load between medial compartment and the lateral compartment. We are talking about the meniscus, which is different from medial to lateral, but how does it reflect to the load?
This load is distributed differently on the medial compartment and on the lateral compartment. In the medial compartment, it is concave medial tibial plateau, so the load is distributed more evenly, while in the lateral compartment it's convex on concave. So you have stress points, and if you lose the meniscus in the lateral compartment, therefore there is an increased load on the lateral cartilage, and you have more risk of developing osteoarthritis as a rapid process, a rapid onset osteoarthritis. And again, it's shown clearly that when you lose the medial or the lateral meniscus, there is an increase, a rapid increase of the forces and the stresses onto the underlying cartilage, and therefore rapid onset of cartilage loss and osteoarthritis. So understanding knee osteoarthritis and the concept of load, so we have the injury and the meniscus loss. Next thing is alignment. Alignment is a very important driver in knee osteoarthritis.
So let's talk about the alignment of the patient. Mm-hmm. So in terms of the load distributions, in terms of meniscectomy, is varus knees important?
What we need to understand is that varus alignment or bow legs is most likely the most important driver for medial osteoarthritis. The bigger the varus, the bigger the medial compressive forces. What is very dangerous in the varus knee is that many patients do perfectly fine when their leg is into varus and their meniscus is intact. But at some point down the line, the first victim of that varus is the medial meniscus. So they get medial meniscus degeneration. And once that degeneration sets in, once that functional loss of the medial meniscus kicks in, then suddenly varus increases the speed of onset. It just accelerates the process of osteoarthritis. But it all starts with a meniscus loss in that knee. Then the activity level. So the next thing is activity level. Again, we need to understand that load into the knee joint is depending on your activity level. If you walk, it goes up to 2, maximum 3 times body weight. If you, however, jump and run, you go up to 8 times body weight. So the activity level has a major implication on the load in a meniscus and on the load in a functional knee joint. The last but very important thing is body mass. So you have the activity level, but you also have the body mass and the body mass index of these patients. Now, what is not important is body mass index, meaning body mass on the length to the square of the patient. It's basically the body mass on the size of the knee joint. So if you weigh 100 kilos and you have a very small knee, the pressure in that knee are huge. However, if you're 100 kilos and you're a tall guy with big knee joints, then basically the pressure in that knee joint is normal. So the size of the knee is a very important part in that body mass on size index. And that's what we discovered recently.
So let's talk about BMI. BMI is important, especially big guys, fat guys. So bigger you are, worse it is, smaller you are, better it is in terms of the meniscus preservation.
But BMI as such is not important. BMI indicates your body mass on the height of the patient to the square. But basically that has nothing to do with the stresses in the knee joint. What is very important is the body mass on the size of the knee, the surface of your knee. If you're a big person and you have a small knee, those stresses in the knee joint will be extraordinary high. However, if you're big and you have also a big knee joint with a large surface, basically the stresses in your knee will not be so high, and therefore these patients have less risk of osteoarthritis. Big and small knee, higher risk of osteoarthritis.
So it's all done. Basically, you have an activity level, you have a BMI, you have a load transmission, and you have an alignment of the patient. So you can predict what will happen after meniscectomy. But the problem that sometimes we have, a lot of times, we have normal, young, active patients with not a big activity and not a big BMI, not big guys, and also completely normal alignment, but after meniscectomy they develop great grade of osteoarthritis. So the sensation that something is missing.
Well, there were patients out there that came to my clinics with a very specific knee shape, what we call a morphotype. These knees were different than your normal knee. And we started identifying these on a two-dimensional MRI image. But we quickly understood that these two-dimensional images were not basically capturing reality, and we needed to do three-dimensional studies. And so we developed this concept of knees that developed early onset medial osteoarthritis in normal, healthy, normally aligned, no obese patients, but they had these small medial femoral condyles. They had these small medial condylar knees, and therefore they had higher peak stresses because the surface area was small. And that was the explanation of a number of patients coming into my clinics with early onset OA, despite the fact that they were normal, no obesity, normal activity level, normal alignment, and still they had early onset osteoarthritis. They had early meniscus tears in the medial compartment. And all of this is driven by contact pressure. And so if you look at contact pressure, basically most of us think about increased pressure, increased load in that medial compartment. But we now identified a knee morphotype where the load was normal, but the surface area was small, hence increasing the contact pressure on the compartment. So basically, normal load, but the lower surface or a smaller surface leads to increased contact pressure and most likely early degeneration of the medial meniscus and the medial compartment. We published this data in 2020, and in this study and this is a pilot study, we started looking into hand-picked cases of patients with medial OA or medial early degenerative changes in the meniscus, and we tried to compare them with knees of normal patients with no complaints in the medial compartment. And so we compared them in a three-dimensional imaging with three-dimensional imaging technology.
So, Peter, it's really fantastic intuition, very innovative, very interesting. But do you have any data to prove it?
So we designed this study where we looked into two groups of patients. I had one group of patients that I handpicked where I identified that their knee had a small medial femoral condyle, and they presented in my clinics with medial osteoarthritis or early medial degenerative tears of the medial meniscus or early cartilage lesions. And we compared them with patients that came for something else with no complaints in the knee. Maybe they had some instability or some random trauma, but these were normal patients. And we compared them on a three-dimensional basis. We looked at them from a two-dimensional analysis, which we called a landmark-based analysis. We identified landmarks and then measured these landmarks and compared them. But we also did a so-called global shape analysis, which is a completely different approach. It's computerized, it's independent of the observer. It's basically the computer doing the analysis of the bone morphotype. What we saw in this in these two groups, the differences that we saw in these two groups were very clear. Basically, small medial femoral condyle had a significant smaller medial femoral condyle measured in the ML direction in comparison to the control group. These differences were situated on the medial femoral condyle and also in that notch/trochlear area. Not only the medial compartment or the medial condyle was smaller, also we saw that the lateral compartment was larger. There was no overall difference in the ML total width of the knee, and there was some difference in the notch width. So it's not only the medial condyle that is small, but it's also the notch that has a bigger size, and the lateral compartment that had a bigger size. Not only in the ML directions, but also in the AP directions, these differences were observed. But basically, these knees are smaller AP-wise in the medial compartment and in the lateral compartment. Work in progress on a finite element analysis showing you the impact of the small medial condylar morphotype onto the load of the medial compartment is still in progress. But we now know that if you look at the stresses and the pressures in the control knee, a normal knee, versus the small medial femoral condylar knee, basically, if the meniscus is inside and is well functioning, the differences are quite limited. There's not that huge pressure on the cartilage. However, if you lose your meniscus, then there is an explosion of forces in the small medial femoral condylar knee versus the normal knee. But so many surgeons ask us, okay, so there is this small medial femoral condylar knee. How frequently is it? How abnormal is it? Well, what we did is we compared our set of small medial condylar knees and we compared them to a huge, large series that is well documented, which is the SOMA database study, which is normal knees. And what we see is that the small medial femoral condylar knee is less than 5% of the normal knee population. So it is extremely rare. In the real world, however, once you go into clinics, then suddenly it becomes very frequent, the small medial femoral condylar knee. And this is nicely presented in this graph, is the fact that the small medial femoral condylar knee is less than 5% of your normal knee population.
So basically what you are saying that the computer model will be able to predict the outcome of the meniscectomy on the patient's knee. That's exactly what you're saying. Can
a computer model predict the outcome of meniscectomy? So what we did is we gathered all this data from these international centers, Milano in Italy, Regensburg, Germany, Antwerp in Belgium, and we looked at into patients, a specific subgroup that did perfectly fine after medial meniscectomy, and the other group of patients that developed early trouble after their partial medial meniscectomy on the medial side. So one group was doing very well to the treatment, the other group was doing really badly after the treatment. And so we tried to compare these two groups using three-dimensional imaging and statistical shape analysis. And what we discovered is that if you look into these two groups, then we discovered that patients with smaller knees, just the concept of having a smaller knee, you develop higher chances for a post-meniscectomy syndrome in the medial compartment. Second principal component is very important, shows you the second principal component is that if you have a bigger notch and a smaller medial femoral condyle, again, you will develop or you have higher chances for developing post-medial meniscectomy syndromes. And then the third principal component is that if you have a higher notch and a higher knee, that you also have higher chances for developing osteoarthritis on the medial compartment. So basically, we now identified morphological parameters to identify patients at a higher risk for medial post-meniscectomy syndrome. And this is unique. So our model can currently predict 80% of the outcome of a medial meniscectomy solely based on morphotype. So irrespective of the status of your cartilage, the alignment, the body mass, your activity level, just the mere morphotype of your knee predicts 80% of the outcome of medial meniscectomy. So the conclusion of this whole concept of the importance of the medial meniscus is this. If you have early onset medial osteoarthritis, I am convinced that body mass is important, your activity level is important, your genetic background is important, your coronal alignment is important, but also the shape of your knee is important. And if you have a small medial femoral condyle knee, even with a normal alignment, normal genetics, normal activity level, normal body mass, you can still develop early onset medial OA. So these 5 parameters are this unifying theory that explains early onset medial OA in your patients.
So now we have to face one of most important chapters also, which is vascularization of the meniscus. Meniscus is almost avascular, in at least 2/3 of the meniscus are vascular, as we all know. But meniscus have really very particular vascularization. Robert, you have done a very, very interesting study about the differences between medial and lateral meniscal vascularization.
What is interesting in the meniscus, lateral and the medial, they have completely different vascularization. Is it important? I try to show you that this is really very important for understanding all the processes like healing, like the injury potential, and so on and so on.
Okay, Stephen, so we will now discuss this most important and most famous picture you ever took of a human meniscus. Can you tell me a little bit more what we actually see on this picture?
Yes, what we're looking at here is a vascular ink injection, the so-called Spalterholz injection technique, where we inject black India ink into the major vessels, and then we section the tissue, and then we clear it using some simple laboratory techniques. And what you see here is the result of that, where the vasculature stands out. And this is the medial compartment of a human knee, looking at the posterior horn of the medial meniscus. And what you see here on the left is the vascular perimeniscal vascular plexus, as we call it, where the vasculature originates from the capsular attachments throughout the periphery of both the medial and lateral meniscus, in this case, the medial meniscus. And importantly enough, this also shows that the vasculature only extends a short distance. And what we found in our studies over looking at 10 decades of age, that it extends about 25 to 30% of the meniscal width. We use that percentage because using exact measurements, 2 millimeters, 3 millimeters, is not always exact, because within an individual and between individuals, that extension varies, again, from about 25 to 30% of the meniscal width. So it gives the surgeon at least some idea of where that tear is, whether or not it's in the vascular area, allowing it to access the vascularity, access the reparative cells, and then go on to repair or heal itself once the meniscus lesion is sutured.
This is another very, very interesting paper written by Scapinelli. You can see on these pictures, you can see the microvascularization, the lateral meniscus and the medial meniscus, and also in the femur and the tibia. But this is very important, how the vascularization is coming into the meniscus, how the vessels reach the meniscus. Another transection, and very important thing, and please compare the lateral and the medial side. The lateral side is really highly vascularized. The medial side, almost nothing, desert. When we make some overlap, the vascularization of the meniscus, and we put these pictures on the top of the pictures of the tibia plateau with 2 menisci, we can see that in these cases, the vascularization of the medial meniscus is mostly concentrated just around in the very small strip. on the lateral meniscus, it looks different with the small gap around the popliteus tendon. And now let's focus on the medial meniscus. What is interesting in the medial meniscus? Anterior root of the medial meniscus is quite highly vascularized, and we can expect also very good vascularization next to medial collateral ligament. We can also, from the transection, we can compare it, and we can also expect the good vascularization in so-called the red zone. We know it from this classification. We have the red zone, red white, and the white zone, and this is quite obvious. We can find that the red zone is a really highly vascularized area, but again, this area here between the meniscus and the medial collateral ligament is the space which is filled by vessels and some small nerves and the soft tissue. From the top, again, these yellow arrows, they show the very specific area in the medial meniscus, because this area, as I showed before, is attached, this part of the meniscus is attached only to the tibia. We have no direct connection from between the meniscus and the femur, but we have the very good connection, attachment, meniscus to the tibia. And you can see here that this is like recess, like a gap in the posterior part of the medial knee. This is the only way to reach by the vessels the meniscus is just from the down to up, from the tibial side to up. What is now? I just did some analysis. You can see here first coronal ligament which attach the meniscus to the tibia. Then we can see how it looks like on this Capinelli work. This is the only way. You can see this is the way how the vessels can just come to the meniscus. And then on the right hand side up we have the histological picture, and this histological picture exactly on this same part of the meniscus, on the zone 4 meniscus. You can see this is the only way for the vessels. This is very important. Even if we talk about the rump lesion, if we cut on this level, if we cut this way, if we close this way, the meniscus cannot get the blood supply. What about the lateral meniscus, opposite to the medial meniscus? In the lateral meniscus, if you look at it, you can see very highly vascularized area around the meniscus, except this small area where we can expect the popliteus tendon. And deeper, again, this Capinelli work, you can see the only way for the vessels to this area is just as what I showed before, meniscofibular ligament, not the normal capsule. Meniscofibular ligament, only way, this is the ligament which is running from the meniscus going down to the top of the fibula, and this ligament is important for the blood supply for this area, for the zone 3. And on our anatomical study, you can see this is we inject the special gel with the color, as you see, to the popliteal artery. You can see here this is the lateral inferior genicular artery. This is the medial inferior genicular artery. This is more or less the joint line. And this small one, this is very interesting artery, because this artery supply the medial meniscus, zone 4 and 5. Going closer, you can compare it. This is more or less 3 times bigger is the lateral inferior meniscal artery than the medial meniscal artery. 3 times bigger. This is very small artery. And add to that, it's curved. It's very uncomfortable place for this artery because it's under the semimembranosus tendon. It's curved here right after the going out from the fleeter artery. Look at this movie. We have the tendon of the semimembranosus, and this is the medial meniscal artery, which is going out from the popliteal artery, And this, if you can see this gap here, these are the branches going to the posterior root of the medial knee. I will show you soon. Can you imagine? This very small branch reaches the posterior root of the medial meniscus. This part is surrounding the medial side of the knee directly to the meniscus. Can you see on these pictures? I just dissect this medial meniscal artery. Through this gap, the branch is going deeper. I will just dissect soon and you will see this soon. It's going deeper to the zone 4 and the posterior root of the medial meniscus. And the rest of the artery is surrounding the medial side and giving some blood supply to the medial meniscus. Now you can see this is the tunnel on the medial side. I will just open this tunnel now. Look at that. What happened? I opened the tunnel and this is POL is lying over the medial meniscal artery. The artery, it's deep, it's very fragile, it's very gentle, it's very easy to close this artery. That's why we have to think about the blood supply if we talk about the meniscus surgery, if we talk about the meniscus repair. And again, medial meniscus artery, very thin, very small one. We just open I will take the tendon of the semimembranosus, small branch, and the artery is exactly surrounding more or less on the level of the joint line. Can you see that? I just dissect the superficial MCL and then we can find out this artery is surrounding and it's connecting to the vessels running to the half of a fat pad. And now imagine that we close this artery and there is no so much possibilities to get the additional blood supply. Again, another picture, nice dissected. You can see the artery here, but the best is coming now. Now I just opened the small gap. I will just go back. You can see, remember this small gap I showed you before. On this movie, you will see this is the this gap I dissected, and these small branches, where they are running. This one is running to the posterior root, and this one here is running to the zone 4. And this is the special technique. You can see very small microvascularization, which is running. One is going to the posterior root, one is going to the zone 4. And if you just overlap it from the top, you can see how it looks like. What we can expect if we destroy these vessels. What we can expect if we have some degenerative changes in the vessels, or let's say small vessel disease. It's more famous in the brain, but we can talk about the small vessel disease also in the knee. This is the lateral meniscus and the blood supply to the lateral meniscus. Please compare the diameter of this artery to diameter of this artery. It means lateral inferior genicular artery, which is the main supplier of the blood to the lateral meniscus. That's why the lateral meniscus heals very well. And if you compare to the medial meniscal artery, which is very thin, very fragile, it could be very easily blocked or destroyed. If we compare it, we can say that lateral meniscus, it's a lucky meniscus, because lucky meniscus has a lot of blood supply. Medial meniscus is miserable meniscus, because it's miserable. We cannot expect a lot from the medial meniscus.
So Robert, what you are telling us is really something new and really something really very exciting, because we always was used to think that lateral meniscus is much more problematic than medial meniscus. Medial meniscus is sort of something always used and easygoing and will heal, and lateral meniscus is complicated. So, which is what you're telling us is opposite. So lateral meniscus is much more vascularized than medial, and so greater possibilities for healing respect to the medial meniscus, so the healing will not create as much problems, and the medial meniscus is really highly problematic.
And this is, in my opinion, this is very important to understand it. Why we can get the problem of the healing of the posterior root and the posterior horn, zone 4. Why we can get also so often the injury or degenerative changes in this area. Because I can imagine that to close the small vessel is very easy. You can see the more curved are the vessels, the more chance for blocking them. Another thing, you have the cholesterol aggregation or something else. The more curved are the vessels, the more chance for stopping and blocking the blood. Anyway, it has very difficult situation. And if we have such curved artery, just a little bit cholesterol, which stop or limited the blood supply. And that is the first step to get the degeneration and the first step to get a very bad very bad healing. I will show you what can we expect when we have the problem with the good blood supply. Can you see that? Very limited blood supply. Even if you have this small stop on this level. What happened when we have the blocking only of the branch going to the posterior root? Then I showed you before. This is the bifurcation here. We have this branch is going to the zone 4, which is here, and this small branch is going to the posterior root. When we stop the branch to the posterior root, we have the typical degeneration on the posterior root. The meniscus start to be extruded, and the posterior root is not holding the meniscus on the proper place. We have the anterior root, posterior root, two very important fixation of the meniscus to the bone, and then we lose one of the fixation because there's some degenerative changes. What happened? The blocking of this branch. Then we can expect the degenerative changes in the zone 4, the posterior horn. And finally, which is also quite common, what happened when we have this small branch which is blocked? Then we can lose the whole posterior part of the medial meniscus from the posterior root to the zone 3 to the border of the MCL, which is degenerated, which is very common view. If you put your camera to the knee, you can see this is very common. The zone 4 is very often degenerated.
So our first chapter of our meniscus discovery series comes to the end. It was a great dive, it was a great journey inside the anatomy, biomechanics, functional anatomy, biology, profiling strategies, thoughts about the future. We meet excellent surgeons, great scientists, legends like Steve Arnowski, and probably we will have a possibility to meet new people, but also to meet them once again in the next chapters. Now we learn much more about anatomy and about a basic understanding of the meniscus. Next chapter will come closer to clinical practice. So we will deal with meniscal injuries. The name of the chapter will be I injured my meniscus. So what should I do? What should I do is a difficult question. Now, after the first chapter, I think we clearly understand that I have to try to save my meniscus, because meniscus is extremely important. So now, we say you goodbye, and we are waiting for you for the next chapter, speaking about meniscal lesions, possibilities of their treatment, and the importance of their treatment and the consequences of the meniscal deficiency.